So I'm really excited to have Dr. Anita Saha here, Teyonna Bowman with us, and so excited to introduce you to these incredible people and have this conversation together. Whether you are navigating surgical menopause, chemical menopause, early menopause, any of it, there's a lot to talk about, a lot to go through. So I'm so excited we have Dr. Anita Saha here. She's very special to me because she's my OBGYN. She has delivered my babies. She has helped me navigate my high risk and survivorship, and most recently my preventative oophorectomy. So I'm so grateful to have you. Will you tell some of our community who you are and what you do?
Okay, besides Allie, I'm an OBGYN in Princeton, New Jersey, and I have been practicing for over 15 years, so I have aged with my patients, and I have been in the same community for over a decade, so I have watched all sorts of patients go through so many life changes and difficulties, and this topic is so timely because this is what's happening next for all of us, regardless of surgical or whatever it is that's happening to us. Menopause will happen to all women, unfortunately. And so this is a good topic that you picked.
Amazing, thank you. And Teyonna is somebody who now I am so excited to call one of my close breasties. I loved getting to know you and preparing for this panel, and I respect you so much, and your story is so powerful. Can you share a little bit about you with our community?
Yeah, sure. I'm super excited to talk about menopause. It's my favorite topic. It actually is. So I'm Teyonna, and I was actually diagnosed with stage 1C IDC when I was 35 years old. It was estrogen and progesterone positive, HER2 negative. And so I went through double mastectomy, chemo, tamoxifen, and right before I turned 40, I actually had a recurrence. And so with that, I had radiation, I had surgery again, and because my cancer was hormone positive, my oncologist recommended that I start ovarian suppression and essentially be pushed into medical menopause with, aromatase inhibitors as well. And so I thought after dealing with cancer twice that I could manage menopause because in my mind it was hot flashes and maybe a couple of mood swings, but I was not prepared at all for the journey that was to come. I felt like I have a very capable team, but this happened just 3.5 years ago, and even when I started my medically induced menopause, the information that was shared with me about what was going to happen was really piecemeal, and it almost felt like puzzle pieces were dumped out in front of me, and I didn't have the picture of what the puzzle looked like, and I didn't know which of those pieces went with menopause, went with cancer, and went with just healing in general. And so it was really confusing. And I had to do a lot of research on my own, ask a lot of questions to understand what was happening with my body and my mind. And as I started to learn more and talk to my doctors about it, I needed an outlet. And so I started blogging, which is kind of old school, but I wanted to share my journey and seek out community to understand what other people were going through and what solutions there were. So I started a platform called Positive Outlook. And that's what I've been doing for the last couple of years. And I'm just very passionate about holding space for this conversation.
It's amazing. I mean, we're not all like Teyonna. I feel like menopause is something that's often like not talked about and hard to talk about and talked about in like hushed tones or not at all. So it's amazing that you are so passionate about this. And, most people aren't. It's something that's secretive, especially like outside of the breasty world. So why do you think that is? Why do you think, people don't talk about it? And what can happen and shift if we do openly talk about it like we're doing today?
Well, Allie, I actually think that social media has put it at the forefront of the conversations. And I'll tell you, I have a 12-year-old who I think has secretly downloaded TikTok. But when I told her that I was coming to do a menopause thing, she looked at me and she said, "Are you in menopause? I think you're in menopause." And I was like, "How do you even know that word?" And she said, "TikTok."
Oh, wow.
So I think it's out there, but I think really the issue from a doctor-patient standpoint is sometimes time. So when you go to your doctor's office and you've gone there for a while and they just schedule you as a checkup, there's not a lot of time that's given for this conversation. And I think that's a huge problem. And I think that it goes well beyond the annual exam. So because I think it is now becoming more popularly talked about, more patients are coming to me, but I honestly look at a lot of them and I will tell them, there is not the time that I need blocked out for this conversation. We will schedule time, and it doesn't even necessarily need to be in person because I'm doing your checkup and all that. We can do this later, but let's schedule an appropriate amount of time to address all of your concerns and actually have like a slow and easy conversation about it so nothing feels rushed, and then people don't feel as awkward talking about it. I think that's part of it too. What do you think? Is that why you got puzzle piece information?
Yeah, I think so. I mean, having a 15-minute time block is hardly enough time to, parse out, well, why am I feeling dizzy? Or, where should I go for XYZ solutions? And I think when cancer patients like myself are being told, okay, you're just going to be put into menopause, good luck. And we don't know if we should be talking to our oncologist, our gynecologist, and there are, sicker patients that are being seen. It's hard to have the conversation.
Yeah, I actually think I tell some of my patients sometimes the oncologist is the enemy because they give you all this stuff and they're treating your cancer. So no one here thinks that the oncologist is the enemy, but then in the gynecologist's office, the patient's like, well, I took all these medicines and I feel terrible and I don't want to tell my oncologist because my oncologist is so happy about my numbers and my progress. And I'm like, okay, we can start from there. But the oncologist ultimately has a different goal than the gynecologist. The oncologist wants your cancer gone, does not want you to have a reoccurrence, and that's their goal. And there are side effects to every medicine we give, right? And so I think the space for the oncologist is to tackle this cancer, right? But I do think a more appropriate space to address symptoms is with the gynecologist.
So true. And I feel like it's so confusing for breasties because we have such a big medical team and sometimes differing opinions, and it's stressful, and you don't know where to go and who to trust and which voice to make the loudest in your head. But I want to touch more on those physical symptoms you're talking about. So Teyonna, can you tell us about some of your experience in menopause and what those symptoms have been like, whether physical, emotional, mental health? I know a lot of us experience this as well, but could you share a little bit about your story?
Yeah, I felt like dealing with the symptoms was playing a game of whack-a-mole. So I experienced extreme dizziness to the point where I was afraid to drive. And I let my oncologist know. And at the time, she wasn't putting together the full picture that the dizziness was actually associated with menopausal symptoms. And so she sent me in for a brain MRI and was talking to me about potential recurrence. I was starting to freak out and start to feel kind of anxiety. I had issues with heart palpitations that sent me to the ER. My numbers were fine, but my level of anxiety just overall and concern whenever I felt any small change or something that wasn't on the list of 38 symptoms that come with menopause, it really scared me. So it was a lot. I think where I felt the biggest changes were at work and with sleep. At work, I had horrible brain fog. I would lose my sentences in the middle of a conference call, and I had a hard time focusing in meetings, and I was in a sales strategy role, and so it was really important that I was on it and very responsive, and I started to just doubt my value in the workplace, and it started a really long cycle of negative self-talk because I just couldn't figure out what was going on. And then with sleep, I I was so tired, but I would dread falling asleep because it was like waking up every 2 hours. And I would do these crazy math games in my head, like just trying to figure out how much sleep I had and whatnot. And so I worked with a therapist who actually helped me with some of the work issues that I had. She helped me identify some of the negative emotions that I was having and name those, not identify with those and take them on. And she helped me set up like a daily gratitude practice, and we actually worked on some supplements to help with brain fog, and that made a difference. And with sleep, my oncologist actually recommended a couple of different routes. She had recommended Effexor, gabapentin, and even I think clozapine. Klonopin.
Clonazepam.
Yes, yes. But at the time, I was taking so many other medications. I wanted to go more of a natural route. And so we actually decided to have me take supplements like magnesium. And one of my nurses even recommended that I take THC gummies to help with sleep. But a more permanent solution that we're working on now is Veoza to help with hot flashes and night sweats and whatnot. But it's an ongoing process. There's so many different symptoms, and it's just a matter of presenting one at a time and trying to address each symptom at a time so it's not overwhelming for me or for my medical team.
You describe it so beautifully, the whack-a-mole. It's such a visual that I feel all of us can relate to. So Dr. Saha, can you explain like menopause for dummies? Like what's actually happening in our body to make our body feel this way?
So I'd like to say before menopause, there is this evil, like 5 to 10 years of perimenopause that I think is less talked about, where you start to have all these symptoms and you're still having your period. So then people are questioning, am I actually in menopause? I have a period, like this is just happening to myself. Like it is a lot of self-doubt, and these are all real symptoms. And what happens in your 40s, or if you are taking some sort of medicine that's affecting your hormone levels, is that your body is particularly sensitive to these hormonal fluctuations. And also, there is less estrogen and progesterone in your 40s, and you feel it, even though you're having a period. And so beyond that first part, the actual hormonal fluctuations are causing your problem before it even gets to the point where you skip a period. So I think everyone talks about menopause, but it's actually all these years before where they say so-and-so's mom's acting crazy, but it's like, it's perimenopause is such a real thing. And this is where people start having memory fog first. I actually think it's a really cruel, sick joke because people tend to go into perimenopause and menopause when your kid is going to like high school or going to college. So it's that much worse for you, you know? And so these hormonal fluctuations are messing with all different parts of your body. So it messes with your brain. It specifically messes with the hypothalamus, which has a temperature regulation system. And it causes you to feel more hot, or it causes you to have triggers that all of a sudden make you hot. And this can occur in perimenopause and menopause. A lot of people in perimenopause first notice at night. They're waking up sweating. And it's random. It'll go and it'll come. And so they don't necessarily identify it as perimenopause. And then there are other things that slowly trickle in. I do think a lot of the vaginal dryness symptoms and pain with sex occur more as you start losing your periods. I don't think that is as prominent as some of the other brain symptoms, if that makes sense.
No, that makes a lot of sense. So for breasties, whether it's, because of medications or surgery, do we go through that perimenopause period, or is it straight to fast forward?
It depends on the medicine. Like, I assume, you said you took tamoxifen.
Yeah.
And you had periods with tamoxifen?
Yeah, I did. And with tamoxifen, it was more like neck up, hot flashes, and just a little bit here and there, but it wasn't like a night and day switch until I started the ovarian suppression and the letrozole.
Yeah, so I think it's an individualized question you're asking. So it depends on the medicine that the oncologist has you on, in terms of whether you're still getting periods or not and how it affects you and your hormones. So some people will have little bits with tamoxifen. I find with anastrozole, letrozole, it's much more exaggerated. And surgical menopause is the worst, is the absolute worst. Your body goes from having something to having nothing at all in 1 second when those ovaries are removed. And there is not one patient I've had who has had surgical menopause that has not complained about severe hot flashes, night sweats. It all comes as an avalanche as they're recuperating from surgery. So I think that is also an arena that's not necessarily, it's more addressed now, but in the past, prior to maybe COVID, prior to 2020, a lot of people, they were told you need surgical menopause. This will help with your, prevent a breast cancer recurrence, but that's it, period. Like, okay, no one said anything about menopause, or it was just assumed that you're going into surgical menopause, so you got to grin and bear it or deal with the symptoms. And I think patients are realizing they don't have to, that there are other medicines. And some of them are obviously not hormonal because they took out the ovaries for a reason, right? So if there is a real reason for that and your breast cancer is potentially hormone receptor positive, you're right. We as your medical team have to find other solutions for you, but you should really challenge your medical team to do that. You shouldn't, I think there was a woman who was sitting here just now that was saying she's a people pleaser and she doesn't want to give anyone a hard time. Like, this is your health care. This is your life. We want you to ask us. We have solutions.
So true. So true. And we're going to get to some of those solutions, whether they be hormone therapy, alternatives. We'll talk about self-advocacy, all of those points. But before we get there, we're talking a lot about the immediate symptoms and the feels that you have in menopause. But I want to talk also about long-term health and how menopause could potentially affect your body and your bones and your heart and your brain long-term, especially for the breasties community. Many of us are forced into menopause before it's supposed to happen to our bodies at a younger age. Could you speak to that a little bit?
I can. I just want to ask Teyonna one thing. When you had all this happen to you, was that discussed with you?
No.
Yeah.
Not completely. What was discussed with me, and it actually gets a little bit to Allie's question, is that I would start to see changes from like a bone health standpoint. And so one of the things that my oncologist did discuss with me is that it would be necessary to do DEXA scans to look at my bone density and make sure that I wasn't going into an osteoporosis direction and take drugs in order to help with that. But the other symptoms, like the brain fog, the changes from an emotional standpoint, and even sexual health wasn't really widely discussed. And there weren't discussions about heart health and the long-term effects of that.
So I just wanted to hear what she said. So when the body is depleted of estrogen, and you go into this menopausal state, it does affect your heart health. People who are in menopause have higher cholesterol. Cholesterol can affect the arteries around your heart and other parts of your body, which make you susceptible to heart disease. These can all be treated with medication, dietary modifications, but people have to know that it's going to exist first, right? And bone health is something that everyone needs to know about. Estrogen protects your bones. Estrogen keeps the calcium on your bones. After menopause, this calcium starts to leach off your bones. And the best way to prevent all of that is to do weight-bearing exercise, to make sure you're not vitamin D deficient, and to make sure you have this healthy diet that has calcium. And these are these other things that aren't necessarily talked about because you're also trying to focus on your cancer treatment, right? But they're these side things because people are surviving from cancer and they need to know these downstream ramifications about what they can now be at risk at an earlier age because of the treatments they sustained. And I think it's really important to this is a primary care doctor conversation too. I tell my breast cancer patients or patients who have some other ovarian cancer or some issue where they're not getting their periods, especially if they're in their 30s, that they should already have their cholesterol being checked, because I think a lot of primary care doctors won't check it until they're in their 40s. And if you have this family history of heart disease and high cholesterol, all that stuff comes out with menopause. So if that's happening 20 years early, you have that much more risk so much earlier. So it's very important to be on top of those things, because something like high cholesterol, you can take cholesterol medicine. You can change your diet. You can do things to fix it, but only if you know it's an issue, right?
Totally. And I know we're going through every symptom, and you said the list of 38, there's probably even more than that, but there's one more I want to touch on before we get to the therapy piece of this and what we can do, and all of those burning questions I'm sure many of us have. I want to talk about sex and intimacy and navigating that. I know we touched a little bit about vaginal dryness, but this is a hard topic, and I know that the last panel too, it's something that was discussed, and understanding how menopause can shift your sense of self and your identity and how to navigate this. So Teyonna, do you have anything to add about this intimacy piece that comes along with menopause?
Yeah, menopause really impacted my identity, but I think even before that, just from a cancer survivor standpoint and getting that diagnosis, I started to see changes from an identity standpoint, because I went from feeling like my body was sacred to feeling like it was something that had to be fixed immediately. And so whenever a doctor or intern or nurse came in, I was completely desensitized, ripping off my shirt. Okay, what do we have to do? I don't care how many people are in the room. And I think just dealing with cancer in general started to impact the mind-body connection that I had. And then after going into sudden menopause, it exacerbated things, because I started to feel just changes overall from a libido standpoint and interest. And my oncology team, again, very talented and very well-meaning, would provide monthly seminars and information about what to expect from a sexual health standpoint. And one of those seminars was titled Use It or Lose It. And the information that was shared was legit, it was medically sound, but for me it was just too real and too fast, because the doctor who was leading the discussion was just talking about vaginal atrophy and how a woman can go from not thinking about her vagina at all to being very aware of it, while she's walking, and your tissue can start to feel like sandpaper. And then her closing notes were, so you have to have sex immediately so you don't lose function. And when I was listening to that seminar, I was just like, okay, I'm 1 month out of surgery. I have radiation that's coming up, and I'm about to start oral chemo. The last thing that I want to do is think about maintaining a vibrant and seamless sex life. It was impossible, and it actually impacted me even more from a mind-body standpoint, and it made me feel a lot of pressure to be intimate. And so that was really hard. And it was hard on my relationship for a long time. I would say that it's embarrassing to admit, but I was so scared of the pain that would come just because of that my husband and I probably weren't intimate for like a year. um, and that takes a toll from a relationship standpoint. And so it wasn't actually until I started going to menopause conferences and talking to some social media gynecologists who started to share the importance of vaginal estrogen and talked about how for hormone sensitive cancers, and definitely correct me where I'm wrong here, but that it's safe for survivors who have had hormone sensitive cancer. And so I talked to my gynecologist about that as well to see if she would prescribe it for me. And she's like, absolutely, let's do this. And I had to work as a bridge between my gynecologist and my oncology team because they weren't fans. But we had to kind of collaborate together so I could use vaginal estrogen. And so using vaginal estrogen, dilators, massagers, all those things were necessary to get things going again from a physical standpoint, but then from a mental standpoint, I actually worked with a sexual wellness coach. And she taught me how to redefine pleasure and to really go inside and reevaluate the things, like simple things outside of intimacy that brought me pleasure, because opening up my mind to experiencing life again in a more pleasurable way was what was needed to reconnect my mind and body. And so we did a lot of breath work to release tension. I did a lot of body scans to recognize the areas of my body that were numb, but not be judgmental about those things, and just be more curious. And so it's been a process. It's ongoing and intentional to just stay present enough and put in the work to have like a healthy and active sex life. But that's hard because I think leaving the treatment center and trying to figure out how to keep that part of my relationship and my identity intact was all on me. And so I definitely think there needs to be more support in that space.
Thank you for sharing that with us. So many of us can relate. And, even in a room full of breasties who get you and see you, that's hard to share. And so, just thinking about how hard it might be to ask for that support from your medical team. So as a provider, what advice do you have for patients who are scared to ask for support, don't know where to start talking about this sex and intimacy piece with their team?
I'm trying to think what I would do in my own practice, but I think as a physician, I ask everybody. Allie knows. But I ask everyone, how are you doing? What is going on? Cancer affects everybody's relationship. And it's also, I have plenty of patients whose husbands have cancer. It's not even them, right? So on both ends, cancer affects intimacy. And truly in any relationship, it is the person and their partner who decide when to resume having sex. And I think from my perspective as a doctor, it's important to tell patients, especially if they have an oophorectomy, for example, or they're taking medicine that causes ovarian suppression, that these are changes that potentially will happen that you can expect. And it doesn't necessarily happen to each and every person, and it's not as extreme for some people, but I think initially having that conversation leads people to contacting me and saying, this is happening. Now, what do I do? I think, to your point, I think some of us don't know if, like, no one wants to push you to have sex, right? Like that's not what any of us want to do. And the same goes after a person has a baby. You know, we're not like, oh, you're done, 6 weeks, go. Like, it's not all that. But I think sometimes doctors also don't know that fine line of, like, we think that's your goal, so we're trying to get you to that goal. But I think it's important for the patient to also dial us back and set boundaries in that way, which can be scary, right? But you know, and have a patient say, I'm not ready to have this conversation, but you know, when I'm ready to have this conversation, I'll talk to you. I think from a doctor perspective that we just need to tell our patients what they can expect with these treatments. And I think the oncologist gives them the side effects in some ways, but they skim over a lot of the sexual and vaginal stuff. So I think it's important when you talk to your gynecologist to say, like, I'm taking this medicine, what are the things I can expect? But it's not 100% that everyone will have sexual dysfunction, but the fear is real. The fear is also real because you've had surgery, you've had chemotherapy, you're recovering, you were in pain. And so sex is not the next natural step. That's not correct. And it's not use it or lose it. And we have plenty of options for people to regain vaginal health to a place they want to be at. Because that's the other thing I do tell patients. Because if you don't want to have sex anymore, that's not my choice, right? And if you're there, then you can also leave it. So for people who aren't sexually active or don't want to be sexually active, it's not that I'm taking letrozole and now I must find a way to make sure I have vaginal estrogen or some sort of vaginal moisture product because this is gonna happen to me. I think these are all individual choices and feelings. And I think that's what this whole conference is about, is sharing everybody's individual journey. And so I do encourage you guys to actually talk about it with your gynecologist, but you probably do have to set some boundaries so we don't misunderstand that, you know, you're ready to get back on the wagon or whatever it is, right? Because that is traumatic.
Totally. And we've touched upon a few things that breasties can do, some different medication options, some things that help with these side effects. I do want to touch upon HRT. And before we get into this, I want to share a little anecdote. So I recently had my preventative oophorectomy 10 weeks ago. And it was a big identity shift going from breast cancer survivor, being diagnosed with triple negative breast cancer, finding out I was BRCA1 positive after that diagnosis. And then 8 years later, navigating my gynecologic pre-Viver journey. And in so many ways, I feel privileged that my cancer was triple negative when it comes to this conversation, because my team was comfortable and I was a candidate and am a candidate for HRT. And that decision was really tough for me to decide what to do, but my team was supportive. And I eventually went that route after surgery. A couple days later, started with hormone replacement therapy, thanks to the support of you and the rest of my team. And I'm feeling good. So I have a lot of imposter syndrome being on this panel because I'm not experiencing a lot of the side effects that potentially could have happened if that wasn't something that was a choice for me. So I want to share that before going in. And recognize that this is a privilege for a lot of us, and some breasties aren't a candidate for this. But can we talk about HRT for a second and what breasties should know and how they can have a conversation with their doctor about what their risk or what their options are?
That's the most important thing, to make patients feel comfortable. Like, you're going in and you're getting your ovaries out, and I have just told you that surgical menopause is awful, right? So everybody here already knows that you're going in for this kind of thing. It's like terrible, and you want to be able to have a plan, and you also want your team to know, like, she got this out. She's out of the woods in terms of risks such as like blood clots and things like that after surgery, and it's okay for her to put this patch on. And that, from the oncology perspective, they care about surgical risks like DVTs and blood clots and things like that after the surgery. But when they feel like you're out of the woods, the gynecologist is there ready to prescribe that patch for you. And hopefully you already have it in hand and you have a plan of what day after surgery you're going to put that on, so that our goal is for you never to have those surgical menopause symptoms. But it doesn't always necessarily work out in terms of timing, but we try to do our best. And for those people who can't have HRT, the oncologist will give you your reason, and we can still work with you and give you other, I don't know if I'm jumping ahead, but
please.
but you know, there are other products on the market and other medications that can help with hot flashes and vaginal dryness and even memory. And there's lots of supplements that also help with sleep. And sometimes it truly is piecemeal. And I actually think it is. Estrogen is the gold standard. If you can get on hormone replacement, a lot of your symptoms will resolve. But if you cannot, it's kind of frustrating but true. We have to attack each symptom. And it helps if the patient outlines for us what those symptoms are, so I can kind of give a game plan of, you have this, let's try this, but let's try this because it'll help with this, right? So there's also a lot of mood shifts and mood changes that happen with surgical menopause or chemically induced menopause. And so there are also some antidepressant medicines that can help with hot flashes. So sometimes we try to get one medicine that helps with two things, that kind of stuff.
Amazing. And I feel like, for me, it was a lot of, okay, let me ask this member of my team, find out their opinion. Let me ask this member of my team, find out their opinion. And all of my team was on board except one. And, it was really frustrating. I was like, okay, this is throwing me off. I thought we were all on the same team here. We all had a good decision, and it was hard to navigate that. So, Teyonna, do you have any advice for people who are having to advocate for themselves to their team? Because I'm not just related to menopause, we have to do that all the time.
Yeah, we do. And it's kind of different from getting a cancer diagnosis because we have a nurse navigator who kind of puts pieces together for us. So my advice would just be to push for what feels right and ask questions. If the response that you get back doesn't feel complete, I think it's okay to ask. I use my chart a lot. And so there's a lot of back and forth that I have with my care team. And I think that it's actually made my discussions with the care team a lot richer because they understand what my questions are. I'm sharing with them the books that I've read, the research that I'm hearing about as well, and asking for their opinion. And so I think that just advocating for yourself is of the utmost importance. It's frustrating to have to be that bridge, but it's necessary. I think that one of the things that you said, Allie, was that it's a privilege that you can use HRT, but I don't think so. I think having a high quality of life after cancer treatment is essential. I think it's something that we're all able to fight for. For me, I had to get over a little bit of survivor's guilt when I did push back and when I was complaining, but we're here. And I think enjoying and being able to be as vibrant as possible is something that we all deserve.
Yeah. That's a helpful reminder. I'm always reminded by this community that we deserve quality healthcare, and you are never a bother by asking questions, and you deserve to get a second opinion if you're not comfortable with the answer that you get. So a reminder to all of you. I know we're probably like near time and dinner's being served, but this is supposed to be Ask Me Anything. We had so many questions for each other. I want to give the opportunity for breasties to ask questions as well. So Jamie's going to come around with a mic to anybody who has questions.
And Teyonna mentioned my chart. It's this patient portal. I actually love it. I don't know. I brought my medical assistant with me, Erin, and I don't know if she likes it as much, but I like it because it really gives the patient an opportunity to thoughtfully tell me things, and I actually like it them to send me even before the visit, because then I'm kind of prepared as to what we're talking about. And so don't feel bad about using it. Okay. And especially if it's, I mean, if it's verbose, it's verbose. But for me, I like the details, and it helps me organize myself in that very little time slot I sometimes get to see patients. So I don't mind it at all.
Hi, thank you all for hosting this panel. My name is Sade. I was diagnosed at 30. And at the end of my treatment, my team decided that I would just stay in chemically induced menopause, and they put me on anastrozole. What we didn't have a conversation about was weight gain. And so from the time I started that to now, I've gained 30 pounds. Are there anything aside from like diet and exercise, the traditional things that, you know, they tell other people that we could do to kind of manage our weight?
So this is hard because I think in menopause, there's also some genetic components to how people gain weight. So in menopause, people start to gain weight more around their middle, unfortunately. And it is much, much harder to lose weight, and it feels like the metabolism is gone. And I think that a lot of people need to just take a step back and also analyze their diet. And my husband taught me about macros, and I tried to ignore it, but it's true. You need to make sure you have a high protein diet and watch the carbs. And I'm a big dessert person, so I'm never going to tell you. I'd rather substitute the dessert for as my carbs, but like you do have to look at your diet. And then also for women in menopause, we brushed on it, this weight-bearing exercise. It's really important to do 2 to 3 days of weight-bearing exercise, and not just like little 5-pound weights if you can, and be active. So in terms of diet and exercise, I think it's helpful to meet with a nutritionist. I personally think a personal trainer is awesome if you can do it, or take some of the classes at the gym where they're introducing weightlifting, because it helps your bones, but it's also going to change how your body looks. But if you're just doing weight-bearing exercise and you barely eat any protein, you're not going to build any muscle, and you're not going to be able to sustain that muscle. So everything kind of comes hand in hand. But beyond that, I think in menopause, people still struggle. Like, I don't like, and I don't think it's as simple as diet and exercise. I know that was your question, but I don't think it's that simple. And I think there is a role sometimes for semaglutide medicines and other treatments. And I think it's important to make sure you've maximized your own diet and exercise before kind of pursuing that direction. But it's not something you should be ashamed to ask for. But just make sure you're good on your own diet and exercise before you get there. That's all. But it is a struggle. It's a struggle for everyone. And it's unfair when you're 30 and your body is put into that postmenopause.
Hi. I have a question about later down the road. So, like my mother, my aunts, and other older women that I know, they no longer have the menopause symptoms. So that I've always been so confused. Like I thought all the symptoms were perimenopause, and like once you go through menopause, then you don't have the symptoms. But I'm in medically induced menopause, and I do have the symptoms. So like, what happens between being in like as you age? It seems like the symptoms aren't there. Is that?
It's not that they're not there, is that your body has gotten used to these hormonal fluctuations or lack of hormone. So some people have terrible perimenopause and menopause symptoms, but as you get farther and farther out, post-menopause, there are people that continue to have hot flashes daily or weekly or randomly with triggers. But there's also people who everything starts to kind of fade away and their bodies get used to a new normal. and they don't have these fluctuations that necessarily trigger this stuff. But everyone's different, right? So there are people that happened. Good for your mom that she doesn't have these symptoms anymore, right? But there are people whose parents are in their 60s and 70s that are still telling you about hot flashes. So it's very individualized. But I do think there's a genetic component. So I'm hoping the same for you. Because if your mom and your grandma don't have these symptoms, I hope you will get there too. But it does eventually happen. It's not forever. But there's no defining time. So does that make sense? So perimenopause, it definitely starts. Menopause is this period where you're not having this period. And then beyond that full year, you're post-menopause, people definitely have symptoms still, but some people don't. Yeah.
Hi, thank you so much for this panel. I think it's really been affirming for me because I am in chemically induced menopause, and it kind of was like, I don't know, I feel like it was like 6 months into chemo. My nurse was like, oh yeah, I was like, I haven't got my period. She was like, you're probably in menopause. I was like, what? She was like, I told you this before. My mom was like, yeah, she probably did. I was like, but I guess it was just so much information, I didn't hear it. And then it just was kind of like glossed over, like, you have cancer. Menopause is the least of your concerns. I'm like, I'm somebody who went from having my period to just not. Like, this is a big deal. So it's just really nice to have this conversation to acknowledge that it is a big deal. I had horrific hot flashes, and my oncology nurse and I discussed it, and they prescribed something which has been like a magic pill for me. Like, it just, day and night from taking it. But all these other symptoms of like the sexual health, lack of libido, I had zero libido, and I kind of attributed it to chemo and radiation and surgery, but I'm like, maybe it's the menopause. So and the brain fogginess. And so I think this conversation has just been really affirming to me, and just to be able to discuss this further with my GYN, because I think because everybody else kind of glossed over it, I glossed over it too. And it is a very big, like, at least when you go through it normally, it's like you have time to process. It just was like one day it was here, one day it's not. And everybody's like, move on, go to chemo. It's like, so I just want to say thank you. This has been really informative and helpful to me, and I really appreciate your candor.
Yeah, I would like to know that too.
It's called, it's not specifically for that, but it works for it. It's oxybutynin. Mm-hmm. It's a magic pill.
What does it do?
So oxybutynin is actually a bladder medicine that helps with urgency incontinence, and I'm going to try it.
It's, it depends on your body
It's
weight.
obviously off-label. Let me ask Dr. Forster sitting there. Do you ever use that? Not for that. Okay, but I'm going to try it.
Yeah.
Yes.
I take
Thank you.
I
Is
take
it twice daily?
Yeah, 5 milligrams twice a day.
So it's actually more than we usually give. Too.
Yes.
Yes. Okay.
It's amazing. Okay, please.
Yeah.
So I learned something too.
Hello, my name is Meredith. Thank you for this panel. I guess my biggest question is, I was medically induced to menopause, and my oncologist, he just looked at me and said, good luck, pretty much. He was like, there's nothing I can do. And I've not been able to find any resources for anything because I have BRCA1 on both sides, maternal and my father. And so I guess I just would like to know, is there anything out there if you cannot take hormones? Like, who should I ask?
I ask patients to write down their symptoms because I didn't know there were 38 different ones, but I want to know what they are. So your question is vague, right? So when you're saying I need help, like I want to know what you need help with, right? So I can help you with that, because it does unfortunately sound like you can't use hormone replacement therapy, but if you outline your symptoms, some of them the gynecologist can easily deal with, right? But sometimes I have people go for the primary care doctor. It depends if it's stuff like sleep, right? But there are different supplements you can use. There's a lot of stuff that's available to you. But I think the important thing is for you to write down your symptoms. And I think Teyonna touched on different supplements, okay? And I would love for my patients to not only come with their symptoms, but a lot of people are using the internet and trying these supplements because they're all over the counter. And I would actually like them to come to me and say, I tried magnesium glycinate. And by the way, it's glycinate because I had a patient who tried magnesium citrate and she was having hot flashes and diarrhea overnight. So magnesium glycinate, right? So they'll write, I tried magnesium glycinate. It kind of helped, but it didn't. Like, I want to know what you tried too. And so then we can have a further conversation about, well, let's try this, right? So you mentioned a supplement that you thought really worked well for you. Was it for it was for memory fog.
Yeah, it was. And I think we have to be careful. It was ashwagandha,
Yeah.
but I had to stop using
Because
it.
of estrogenic properties.
Yeah. And so it's making
snuck
sure
it
that
in there?
we share the information and
Yeah.
it could make a big difference.
So the problem is these supplements are also over the counter, right? So no one is telling you that this could be a phytoestrogen or an estrogen when they've specifically told you don't take estrogen, right? And so some of my patients are like, this is a miracle. Costco sold me Estroven and I am good. I'm good. And I'm like, oh God. And they got 120 tablets and so exactly you got to find somebody else to give those supplements to, right? And it's just some of it's a little dangerous. You just got to be careful, especially if you see on the bottle that it says anything with the word estrogen in there. Please talk to somebody. And potentially talk to your gynecologist and not your oncologist, because it sounds like a lot of the oncologists, if it says estrogen anywhere, they're done. But you see.
I feel like too, these types of conversations like open up resources. And I know we could talk about this for hours. We'll take a few more questions, but Teyonna, do you want to summarize quickly? We put into the Sketch app under the session description, right before this session, we added, Teyonna put together an amazing list of resources like podcasts, books. Do you want to just quickly share what's in there so people can look for it?
Yeah, there is a list of menopause resources like the Menopause Society and Ishwish, and it just has information about different symptoms and potential questions to ask your doctor. So definitely click on the Sketch app. There are a couple of doctors who are also very well-versed and vocal about the menopause journey in general. Some specialize in cancer survivors. Others are generally kind of moving forward with the menopause movement. So there are Instagram accounts on there to follow and then books. So definitely spend some time in there.
It's an amazing list.
Hi, I'm Michelle. I have a question specifically about supplements. And I know that you kind of touched on that just a little bit, but I was a personal trainer for 20 years before my cancer diagnosis. And even after my diagnosis, I have been going to the gym. I do heavy weight training. I eat really well. I'm doing all of those things, but I am also estrogen positive, HER2 negative, and I can take HRT. I was on HRT for 3 weeks, and that's when I actually found my tumor, unfortunately. So I was kind of sad that I had to get off of it. But anyway, my question is this. For someone like me who is, I'm on an anastrozole and I do a Lupron injection every three months. And it's been about a year of me being on anastrozole and Lupron. The side effects that I did have was light hot flashes, but I noticed that the hot flashes get more intense depending on what I'm eating. So if I'm eating like anti-inflammatory foods like sugar and like spicy foods and all the things that I love, sometimes my hot flashes are more prominent. The only thing I've really had was issues with my hands, like this hand thing that everyone's talking about, this anastrozole like numbness thing. Now, when I speak to my oncologist about the symptoms, the first thing that they're saying is, what are you eating? But then they're also like, let's give you a prescription for PT. Then they send me to PT and I'm going to physical therapy for a hip impingement or something for my hands. And I also want to just make sure that besides doing all the things that they're asking me to do, that I'm also supplementing the right way. So just like with her, someone said, ashwagandha, you should take that.
I then go to my oncologist. Should I take that? They say no. I go to my gynecologist. They're like, well, maybe, depending. So it's really kind of confusing going between the two doctors and asking them what's what, lion's mane and all those other things. So my question is this. If you had to give advice to someone in my position about the most basic supplement, I'm taking calcium, a vitamin D, just a basic multivitamin, and magnesium. I have to figure out which one it is because I have two types, one for the brain and the other kind. So my question is, if you can just say, like, what do you mostly recommend that would be the right thing for someone in my position?
So it's hard because it's individualized, right? But I will tell you, don't worry. Decreasing estrogen levels cause a decrease in melatonin. And so that is part of the perimenopause and menopause sleep disruption beyond having night sweats and waking up. So I do tell patients that they could try melatonin because your body circadian rhythm, as the melatonin rises, you fall asleep, right? So that's one of the things you can do. And then this is, again, piecemealing different symptoms, right? But melatonin can help. Magnesium glycinate is great for everybody of all ages, and I recommend it to everybody because it helps muscle relaxation, so it helps people who exercise a lot too. It helps with sleep. And so those are ones that I tell people about all the time, okay? There are some studies that look at something called magnolia bark for sleep also. And then some of my patients have tried that and feel that that works better than magnesium. But there's no anti-estrogen there. So these are different things you can try. I think beyond those supplements, I think it's very important you're doing the things. You have this trainer, you're lifting heavy weights, your diet is good, you're building muscle because you have protein. I like collagen. I think collagen's great for everyone going through menopause. Your skin becomes dry with menopause too. So collagen's great for hair thickening, because we didn't talk about hair loss too, but hair thickening, your nails after chemo, right? And so collagen, I think, is a good supplement that's safe. Okay. And beyond that, I sometimes just talk to patients about what they're doing, but there's not very many over-the-counter supplements that I tell everyone to take beyond what you're already taking.
Okay.
And vitamin D is always very important. And it's important for you to make sure with your primary care doctor too that your vitamin D is normal. So, and if it's not normal, take the vitamin D supplement. It's important.
Thank you.
Hit the side of the room.
Hi, thanks for this panel. My name is Leora, by the way. I was placed in surgically induced menopause in November 2023. Allie, I have a very similar story to you. And something that I'm navigating right now, I'm also triple negative, and I've been navigating having the conversation about HRT with both my gynecologist and oncologist. And I didn't take anything before my surgery, and now I'm November 2023, however long that is to now. I started vaginal estrogen maybe like a month ago, and that's been amazing. But my question is about how do you navigate the conversation with, say, your oncologist or any other healthcare provider about long-term health? So I'm having symptoms now, and I'm managing them, but I'm really concerned about, and as a survivor and in survivorship, my long-term health. And my oncologist she doesn't really factor that into the conversation, and she's only telling me, well, you can do HRT if your symptoms are severe now. And I'm saying, I'm having symptoms. What you consider severe and what I consider severe may be different. But I'm also thinking now, for the first time, I'm 11 years out from diagnosis, about my health long term. And I never even let myself go there for the longest time because I was just trying to get to the next year, another anniversary. But she's not really talking about it as an option for long-term health concerns that I am concerned about in the future, like bone health, cardiovascular health, brain health. And I'm having trouble navigating that conversation with my oncologist, and my gynecologist is speaking with my oncologist. So I have an appointment with a new gynecologist on July 1st, who I'm hoping might be a little bit more open to that conversation. But for any other of the women sitting here who are thinking maybe about long-term health, and yes, we need to manage our side effects that we're having today, but what is there any advice that you could give for how to have that conversation about maybe some of those long-term impacts that being in surgically induced menopause or chemically induced menopause at such an early age? Like, how do you have a conversation about concerns you're going to have when you're 50, 60, 70 years old, God willing?
So, well, you can correct me on this. I approach it as I basically, I'll say you're 35 and they took your ovaries out. Most people go into menopause around 50. So you've already 15 years that they've taken away, in terms of, like, a lot of people, their cardiovascular risk goes up, heart attack goes up, all these things go up after menopause, and that's usually around 50. Right? So all of a sudden we've pulled you back 15 years. And I'm pretty blunt. So I have these conversations where I just say, like, you're 15 years behind now, right? And so we need to stop this as soon as we can so that your body doesn't have all of these effects, and that you're right, that you develop osteoporosis at 45 years old, right? Like, you don't want any of this. And it is all prevention, because right when you start your surgically induced menopause or your chemically induced menopause, you're okay right there. And then it's all prevention from there. So the more years that pass, things can degrade, but it's not to say they can't be built up again. Okay, so the sooner you catch it, for example, a lot of people's oncologists will do the DEXA scan. I think if you're at the point with your oncologist that long-term health isn't necessarily the conversation, I do think the primary care doctor is a great place to have this conversation, because they are the ones managing your cholesterol. Either the gynecologist or the primary care doctor will do bone density scans, and usually the oncologist isn't checking your vitamin D level. So I think beyond your oncologist and your gynecologist, do you have a primary care doctor that you can also talk to about this stuff too?
Yes, and I have an endocrinologist. So there's like a billion, and a gynecological oncologist. So there's many conversations that you could be having, but ultimately I feel like they defer to the oncologist.
Yeah. Teyonna, do you have any advice for just like navigating that dynamic, and like any advice to make that a priority and communicate that as a priority when maybe that's not the oncologist's first thought?
No, I don't. I actually think that's the biggest gap, for us, because again, like, when the diagnosis comes, there's like, okay, here's what you're gonna do. We have a nurse navigator. We're gonna block and tackle for you, all these things. But I think after active treatment ends and survivorship begins, there's no, there's no path for how to make this all kind of work for us. And I think, to Dr. Saha's point, it's like, okay, let me get reacclimated with my PCP. But if our PCP are just sending us around this loop, I think it's
they're
an issue.
deferring to your oncologist. Like, it's your bones. I can't answer that question, but I'm not sure, because I do this stuff myself.
Yeah,
right.
I would love to connect with you after, because I feel like we have, like you said, very similar stories. And I shared the one member of my team who wasn't against it, but just said, why don't we wait and see how you feel, and then we can tackle your symptoms first, and then when we'll worry about HRT if we get there. And that was my concern. I said, I want to think long term, and the rest of my team was thinking, okay, yes, we're also thinking long term. So I had to push for that piece and maybe be okay with going against that provider's opinion and finding other providers who could rally with me to have that conversation and make a decision, even if it was against one of the team's advice. And second opinions, you deserve one. You do.
And potentially rephrase, right? at this point, you're worried about your long-term health, and that is actually the primary care's job, right? The oncologist has done their job. So, potentially rephrase to your primary as, I am worried about my long-term health. I'm worried about my cardiac health. I'm worried about my bone health. How can you help me, right? Not talking about cancer even anymore. Talking about, this is potentially the age of menopause. What do I need to do given that 35 is the age of menopause? So moving past the cancer, so the oncologist isn't necessarily even that part of that conversation.
One thing, can I just add, and it's not going too political, but I know that there is energy, and there is some work that's happening on statewide levels to just increase menopause education overall and make it a requirement for CMEs. And so I think as we start to have more conversations about multidisciplinary, approaches to survivorship and menopause education, that's where maybe we're doing less of the work. And hopefully that will start to come across from a legislative standpoint.
Yeah. I think we are out of time. This conversation could go for hours, could last all weekend. We're available to you. Come find us, come say hi. You could come up and ask questions. But thank you for being here. Thank you to Dr. Saha and Teyonna for being a part of this panel. We appreciate you.